Hey everyone, welcome back to all my listeners. This is episode 13 in season 17. Today is Wednesday, April 29th, 2026. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. All right, you guys. So, we are approaching the very last day of the month of April, and I wanted to remind my audience that today is going to be a heftier episode, simply because it is one of my favorite episodes, the Newsworthy Fraud, Waste, and Abuse highlights for the month of April 2026. And of course, I'm going to want to spotlight some of those from the month's criminal and civil enforcement cases that I find newsworthy. And in my trusty tip, I'm going to go ahead and focus on compliance recommendations for documentation. And in Spark, I'm going to go back and round out today's episode with a remarkable quote on beauty, abundance, and innovation by Brian Tracy. All right, you guys, let's get into it. So in today's Newsworthy, the month's fraud, waste, and abuse cases. The month of April saw 38 cases as of the recording of this episode. So let's check out some of the cases that I want to spotlight. April saw Trinity Hospital agreeing to pay $1.7 million to resolve alleged Stark Law violations. Trinity Hospital Holding Company, or Trinity, has agreed to pay the United States $1.7 million to resolve allegations relating to improper financial relationships between Trinity and two referring physicians. Trinity operates a hospital located in Steubenville, Ohio. Trinity disclosed the arrangements at issue to the government following an independent investigation. The physician self-referral law, commonly known as the Stark Law, prohibits hospitals from billing for certain services referred by physicians with whom the hospital has a financial relationship, unless that relationship satisfies one of the law's statutory or regulatory exceptions. The settlement resolves allegations that from 2014 through 2020, Trinity made improper financial contributions to two referring physicians in the form of rental arrangements for office space. The United States alleged that these arrangements violated the Stark Law because the rental arrangements exceeded fair market value. In connection with this particular settlement, the United States acknowledged that Trinity took significant steps entitling it to credit for cooperating with the government. Following an internal compliance review and independent investigation, Trinity promptly took remedial action, disclosed the relevant arrangements to the government, and cooperated with the government's investigation. The claims resolved by the United States in the settlement are allegations only, and there have been no determinations of liability. April saw Advanced Urology and Jitesh Patel will pay $14 million to settle False Claims Act case involving allegations of fraudulent billing and unnecessary medical procedures. Jitesh Patel, MD, Advanced Urology, Inc., and affiliated companies will pay $14 million to settle allegations that they violated the False Claims Act and the Georgia False Medicaid Claims Act by billing federal health care programs, including Medicare and Medicaid, for a series of urological and diagnostic procedures that were not performed or were medically unnecessary. The government's investigation began after a former Advanced Urology employee filed a whistleblower complaint alleging that Advanced Urology performed unnecessary procedures. A former Advanced Urology physician filed a second whistleblower complaint alleging that the practice billed government healthcare programs for procedures and tests that were not performed or were medically unnecessary. The whistleblowers alleged that, among other things, Advanced Urology's organization was designed to maximize revenue for Dr. Patel and others by performing medically unnecessary procedures and tests by engaging in the following practices, among others: implanting permanent sacral nerve stimulator devices in patients without first determining whether the patients would benefit from the device, performing numerous unnecessary cystoscopy and retrograde pyelogram procedures, which involved placing a patient under anesthesia and inserting a small scope through the patient's urethra and into the bladder, performing an electromyography test on almost every new patient at the advanced urology practice, even though it is rarely used in urology practices. This test involved transmitting electrical signals through an electrode attached to the patient's genitalia. And finally, ordering thousands of unnecessary ultrasound tests, including duplex ultrasounds and retroperitoneal ultrasounds. The whistleblowers also alleged that Advanced Urology billed for a procedure known as direct visual internal urethrotomy that it never performed. The direct visual internal urethrotomy procedure involves a scope to dilate a patient's urethra and a knife to cut tissue inside the urethra. Allegedly, Advanced Urology performed a less complicated dilation of the urethra, but billed government healthcare programs for a direct visual internal urethrotomy to obtain more payment than it was owed. The whistleblowers alleged that Advanced Urology and Dr. Patel's conduct resulted in the submission of false claims to federal healthcare programs, including Medicare and Medicaid, in violations of the False Claims Act and the Georgia False Medicaid Claims Act. This civil settlement resolves two lawsuits filed in the U.S. District Court for the Northern District of Georgia under the QTAM or whistleblower provisions of the False Claims Act. Under the False Claims Act, private citizens may bring suit for false claims on behalf of the United States and share in any recovery obtained by the government. The relators here will collectively receive over $2.9 million from the settlement. The claims resolved by the settlement here are allegations only, and there has been no determination of liability. April also saw National Partnership of Insurance Brokers and its former subsidiary agree to pay over $160 million for Affordable Care Act enrollment fraud scheme. AP of South Florida LLC, or APSF, an insurance brokerage company headquartered in Florida, has agreed to plead guilty for its role in an Affordable Care Act, or ACA, enrollment fraud scheme. APSF, through its highest-ranking executives, preyed on thousands of vulnerable consumers to fraudulently enroll them into fully subsidized ACA plans, for which the federal government awarded $141.5 million in unwarranted subsidies. In a parallel civil resolution, Assured Partners, Inc., a national partnership of insurance brokers, and the then parent company of APSF agreed to pay $135 million to resolve allegations that it violated the False Claims Act by submitting fraudulent ACA health insurance plan applications. Assured Partners, Inc. is not charged in the criminal information. The criminal case. The federal government offers subsidies to help eligible beneficiaries pay for health insurance plans. These subsidies are offered as tax credits to beneficiaries or as payments to insurers as advanced premium tax credits, or APTCs. APTCs are paid directly to insurance plans by the federal government in the form of a payment toward the beneficiary's applicable monthly premium. A criminal information was filed charging APSF with one count of major fraud against the United States. APSF has agreed to resolve the criminal charge by pleading guilty and paying restitution of $27.6 million. As part of its plea agreement, APSF admitted that through certain of its executives and employees, APSF knowingly and intentionally defrauded the federal government. According to court documents, APSF targeted vulnerable low-income individuals experiencing homelessness, unemployment, and mental health and substance abuse disorders, and through, quote, street marketers working on APSF's behalf, sometimes offered cash and gift cards to induce those individuals to enroll in subsidized ACA plans. APSF enrolled these vulnerable consumers in ACA plans that were fully subsidized by the federal government by submitting false and fraudulent applications for individuals whose income did not meet the minimum requirements to be eligible for the subsidies. As a result of being enrolled in subsidized ACA plans for which they did not qualify, some of these consumers experienced serious disruptions in their medical care or prior insurance coverage under Medicaid or other programs. Some consumers who APSF fraudulently enrolled into fully subsidized ACA plans lost access to free health benefits through Medicaid or other local assistance programs, and as a result, these consumers faced increased costs in accessing HIV medication, medication to treat opioid dependence, and medication to treat mental health disorders. At times, consumers faced unaffordable copays and other costs because APSF enrolled these consumers in plans without regard to the consumer's medical needs, the availability of other programs, including Medicaid and local assistance programs, and the consumer's ability to pay out-of-pocket costs. The civil case. The False Claims Act settlement resolves allegations that from February 2021 through September of 2022, APSF knowingly submitted false or fraudulent applications for subsidized ACA plans on behalf of thousands of consumers in order to obtain commissions and bonus payments from insurers. APSF contracted with quote-unquote street marketers who targeted homeless shelters, bus stops, drug treatment clinics, and other similar locations. The marketers offered incentives such as cash or gift cards to individuals to enroll in subsidized ACA plans or to provide their personal information so that APSF could submit applications on their behalf. APSF employees then submitted applications falsely representing that the consumers would make a minimum income amount just over the federal poverty line in order to cause the government to pay the highest subsidy amount. APSF employees also knowingly submitted false information to Florida's Medicaid program in order to generate letters stating that the applicant was denied Medicaid coverage and then used these letters as a qualifying event to trigger a special enrollment period, which allowed APSF to submit applications for ACA plans outside the normal enrollment periods. APSF employees also evaded the federal government's attempts to verify information in consumers' ACA applications by submitting false information in response to inquiries from the Centers for Medicare and Medicaid Services when it sought to verify the false information, including income information, submitted by APSF. Some consumers experienced disruptions in their medical care as a result of being enrolled by APSF in subsidized ACA plans that did not provide coverage for their medical needs. APSF received commissions, bonuses, and or other payments for consumers it enrolled in ACA plans, and a significant portion of APSF's revenues from these fraudulently obtained payments flowed up to its then parent corporation, Assured Partners. The settlement resolves allegations originally brought in a lawsuit filed by a whistleblower under the qui tam provisions of the False Claims Act, which allow private parties to bring suit on behalf of the government and to share in any recovery. The whistleblower here will receive $24.3 million as their share of the recovery in this case. The claims resolved by the settlement here are allegations only, and there has been no determination of liability in the civil settlement. April also saw a podiatrist and pharmaceutical sales representative sentenced in a $3.2 million healthcare fraud conspiracy involving unlicensed person performing skin grafts. 2 men were sentenced to 63 months in prison for conspiracy to commit healthcare fraud. Judge Thurston also ordered forfeiture of 9 properties owned by the men, as well as a $2.6 million personal forfeiture money judgment against one man, and a $12.1 million personal forfeiture money judgment against the other. According to court documents, one man was a podiatrist and the sole owner of West Coast Podiatry, Inc., a podiatric medical practice with locations in Fresno, Madera, and Stanislaus counties. The other man was a pharmaceutical sales representative who sold skin grafts to the other man and WCP. The pharmaceutical sales rep was not licensed to practice medicine. Between June of 2021 and January of 2024, the owner purchased skin grafts from the sales rep and permitted him to apply skin grafts and perform other medical procedures on patients suffering from severe wounds, including foot amputations. Application of the skin grafts required sharp debridement, which means using a scalpel to scrape the wound until it bleeds. Some patients believed the sales rep was a physician, referring to him as, quote unquote, Dr. Gabe. He would perform medical procedures alone without supervision from a trained physician. The men submitted fraudulent claims to Medicare, Medicaid, and Medi-Cal that falsely represented that the owner and other physicians had performed the medical procedures, such as applying skin grafts to patients when it was the sales rep who had actually rendered the services. In one example, WCP submitted $150,000 in claims to Medicare in 2023, claiming a physician performed the procedures when in fact the physician was out of the country on vacation. In another example, the sales rep cut into patients with recently amputated feet with a scalpel and applied skin grafts without a physician's supervision. The owner allegedly knew about the sales rep's conduct and dismissed staff's concerns about him. Throughout the period, staff and third-party auditors raised concerns about their billing practices. The two men ignored those warnings and continued to bill Medicare and Medicaid for services performed by the sales rep. As a result, the owner submitted approximately $3.2 million in false claims to Medicare, Medicaid, and Medi-Cal between the years 2021 and 2024. April also saw a Metro Detroit surgeon was sentenced to a year in prison in $7 million Medicare fraud scheme. A surgeon from Metro Detroit was sentenced for his involvement in a scheme to submit fraudulent claims to Medicare for psychotherapy services. The 79-year-old man was sentenced to 12 months in federal prison. He was also ordered to pay $4.8 million in restitution and to serve a 3-year term of supervised release following his incarceration. According to court documents, between the years 2019 and 2023, the man and others joined in a scheme to submit more than $7 million in fraudulent claims for psychotherapy services, which were never rendered. He joined with one man in signing purported patient progress notes, which were actually written by employees in Mexico rather than by actual medical providers. And finally, April saw a eye practice and physician owner agreeing to pay $415,000 to resolve allegations of False Claims Act to Medicare. The Mitchell Eye Center, a Florida ophthalmology practice, and the ophthalmologist and former owner of the Mitchell Eye Center have all agreed to pay $415,000 to resolve allegations that they caused the submission of false claims to Medicare in violation of the False Claims Act. The United States alleges that from September 2018 through March of 2020, Mitchell Eye Center caused the submission of false claims for transcranial Doppler, or TCD, tests to Medicare and the Veterans Health Administration. A TCD test is a non-invasive diagnostic test that can be used to estimate the blood flow through certain blood vessels in the brain by bouncing high-frequency sound waves off of blood cells. As part of this settlement agreement, the Mitchell Eye Center admitted to and accepted responsibility for facts underlying the settlement agreement. Mitchell Eye Center had contractual agreements with an independent medical diagnostics company, IQity PLLC, during the relevant time. IQity paid Mitchell Eye Center for every referral that the Mitchell Eye Center made for TCD tests, even though the parties' contracts called for payment based on fair market value of rent and administrative services rendered, and not per patient or per test that Mitchell Eye Center referred to IQity. When documenting the purported medical necessity of the TCD tests for Medicare to cover the costs of the tests, Mitchell Eye Center physicians also signed order forms that IQity had provided, indicating that the patients had vertebrobasilar syndrome or vertebrobasilar insufficiency, a very rare condition. But Mitchell Eye Center physicians did not have reason to believe that patients had a diagnosis of vertebrobasilar insufficiency. The United States contends that the claims for the TCD tests that the Mitchell Eye Center caused IQity to submit to Medicare were false because the TCD tests were not medically necessary and because the Mitchell Eye Center received payments from IQity that violated the anti-kickback statute. And now it's time for my best practice tips in Trusty Tip. Let's talk about documentation, one of my very favorite topics. The National Government Services webpage houses great FAQ pages. They've updated many of them in April. So I want to focus on their frequently asked questions and answers for documentation. Number one, what are the basic documentation requirements for a service submitted to Medicare for payment? This is a great basic question that has a fantastic answer from the NGS MAC in my region here in the state of Illinois. And don't forget that I already disclosed last week or the week before, I can't recall, but NGS has now partnered up with WellPoint Federal. So keep that in mind as well. The web page is still the same under NGS, but they are now partnered up with WellPoint Federal. Now, let's go over the question again since I digressed. Number one, what are the basic documentation requirements for a service submitted to Medicare for payment? Answer. For all services submitted to Medicare, the medical record, whether electronic or paper, must clearly define the provider of the service and the date on which it was performed. When a service definition includes a time requirement, that time must also be documented in the medical record. This may be done as quote unquote clock time, which means from 11 a.m. to 11:30 a.m., or as total time spent, for example, 30 minutes. Question number two that came in is, please advise on whether documentation by a student nurse co-signed by a staff RN is sufficient to support a hospital facility fee. NGS comes back with their answer, and they say a nursing student's documentation may not be used to support a billed service to Medicare. In order to bill the facility fee, a nurse employed by the hospital must document the service. Number three, the question that came in was, how long does a provider have to complete a note? When do you consider a note incomplete? This is a great question. I get this all the time from so many people that write into me for my service called Sonal Says. So this is a great question, and I deal with it all the time in the everyday work I perform. What does NGS have to say? Answer. Providers are expected to complete service documentation, quote, during or as soon as practicable after it is provided in order to maintain an accurate medical record, end quote. Although CMS does not define a specific time frame. And of course, that is according to the CMS Internet Only Manual, publication 100-04, as well as in the Medicare Claims Processing Manual, Chapter 12, Section 30.6.1. However, I go even a bit further than this answer from NGS when I am providing advisory services to my clients. I always recommend best practice tips are within 72 hours that provider, practitioner, APP, MD, DO, whoever is signing that note, they have 72 hours to close it out. I think that is a perfectly acceptable time for things to be tied up in a bow, so to speak, right? So even though Medicare, the CMS, and NGS here specifically say that there is no such exact time frame, it has to be as soon as practicable, that's a hard word to say, as soon as practicable after it is provided in order to maintain an accurate medical record. So definitely go with whatever your payer guidelines state. However, when I am providing my provider education, as I'm auditing, as I'm developing their compliance programs, I always try and make sure to advise them that they need to have some sort of a policy to really close that note up with a bow within 72 hours. I think that's perfectly fair, and that gives the providers at the organization a deadline, right, of when they have to get things tied up in a bow appropriately before they send those claims out the door to the payer. And their answer continues and states, a note is incomplete when it does not support the elements of care represented by the billing code and is not dated and signed clearly by the performing provider. Generally speaking, the service should be documented on the same date on which it is performed, since the documentation of date and signature must correlate to the date of service on the submitted claim. So there you go. So they tried to push back a bit more and give some more guidance, right? Not just the very vague guidance that is provided by the CMS in the publication manuals. So, we really have to emphasize the fact, especially as the payer auditors come back with even more scrutiny, it's really good to have some sort of a policy in your compliance program that helps support what the organization is doing in terms of closing up their notes, be it electronic or be it on paper. It's a really good idea to have a deadline for our practitioners to make sure those notes are signed and dated. All right, question number 4. If there are not 2 patient identifiers on the medical record documentation when reviewed, will the service be paid? Are there any requirements for patient identifiers? NGS comes back with an answer. Well, technically, it's WellPoint Federal has their answer. WellPoint Federal Medical Review will accept 1 patient identifier on a record, usually the patient's name and or MBI number. So there's a great pro tip there, is that WellPoint Federal has now reduced the amount of patient identifiers from, it's normally 2, they've reduced it down to they will accept 1 patient identifier on the record, usually the patient's name and or the MBI. Question number 5 that came in is, how should time be recorded in the medical record? Another great question. What does NGS have to say? Their answer is, although CMS does not define a specific time recording rule, we strongly recommend that time spent rendering a service or services is included in the associated notes. The preferred format is, quote, 11 a.m. through 11:45 a.m., although, quote, time spent 45 minutes, end quote, may also be acceptable. I completely agree with that. Question number 6 that came in. With EHR, what do you give credit for if the notes are cloned from one visit to the next? Do you look for any specific documentation from the provider in order to give credit for past medical, family, and social history? Yeah, I just talked about this in last week's podcast drop, right? I talked about cloned records. Yes, this is such a dangerous, slippery slope here as we are auditing things. So what does NGS, WellPoint Federal have to say? They come back with their answer. Cloned notes are strongly discouraged unless there is clear documentation that the examiner has reviewed the prior material. Absolutely, right? But that is rare. I hardly see the fact that Dr. Patel reviewed that information from the items on the EMR that have been cloned or copied forward, right? It's a great idea to say, I've reviewed this information, making the review itself valid, right? And then disregarding the fact that it is identical or duplicate information from the day before. So long the provider makes it known that they have taken the time to review it, right? And all of that review goes into their clinical judgment for today's date of service, right? All of that is very, very encouraged type of behavior that we would like to see. And clearly NGS is agreeing here. So clone notes are strongly discouraged unless there is clear documentation that the examiner has reviewed the prior material with the patient and updated it as necessary. They go on and say, when the past family social history is copied from a prior visit note, the examiner is obliged to indicate that it has been reviewed with the patient and updated as necessary. Bringing prior verbiage forward into a new note must be medically necessary and pertinent to the encounter. Adding voluminous verbiage from prior visits is usually not medically necessary. That's really, really well said, right? It's short and sweet. They want our practitioners to realize that if you are copying things forward, carrying things forward, if your EMR is pushing you to do that, you need to actually be reviewing the items with the patient and making it clear that for this date of service, this review from the past PFSH is actually necessary, right? And it helps the provider construct the treatment for this particular date of service. So I thought NGS and WellPoint Federal did a great job in answering that, is that best practice is it always has to be medically necessary if you're carrying that kind of information forward, if things are cloned. Next question, number 7. When reviewing documentation, should the diagnosis always be listed in the assessment and plan, or will they allow it to be extracted from the note? Answer. For the purpose of clarity, the diagnosis should be listed in the assessment and plan, especially since the number and complexity of diagnoses will be factored into the level of complexity for the visit. The patient's chief complaint may include reference to the diagnosis or may be phrased in the patient's own words as the reason for the visit. But the diagnosis billed on the claim is expected to be clearly stated in the provider's assessment and plan. So there you go. This is what NGS and WellPoint Federal consider need to be documented, right, to support the diagnosis billed out on those claims. Number 8, the question that came in is when records are requested for medical review and or appeals, what should be submitted to support reference to information documented at a previous encounter? The answer. When submitting records for medical review and or appeals in which previously recorded information is referenced, both records must be submitted in order to assess the correct level of coding for the service in question. Yeah, I can't stress that enough. Absolutely. We have to include all supporting documentation in a medical review or appeal situation, right? That is why so much continues to be denied at the appeal levels, right? Because there's still insufficient documentation, which means we need to really go back and include the records from previous services, right? Where the potential of the medical necessity lies with records and dates of service from before. So this is exactly what NGS is emphasizing as well, right? So both records or multiple records, right, must be submitted in order to assess the correct level of coding for the service in question. Could not agree more. And finally, NGS's last question, number 9, that has come in for the month of April, is what elements are expected to be included in documenting interpretation of an EKG? I love this question because I provide this answer to my teams all the time in what is required. The answer that NGS and WellPoint Federal come back with is documentation for both electronic and manual EKG interpretation must include a description of the cardiac rhythm and rate. The P, the QRS, the T complex width and duration, as well as intervals, including the ST segment, the cardiac axis, and, if available, a comparison to the most recent prior tracing. The reviewing provider's signature is required on any interpretation for which the provider is submitting a claim. And finally, I want to continue season 17's focus on beauty, abundance, and innovation in Spark. So in this week's inspiring quote in Spark is from Brian Tracy. If you can dream it, you can do it. Your limits are all within yourself. So very true, right? I love this quote on abundance, the abundance of dreams. There is no such thing as a shortage of dreams. Dream big. Don't let fear stop you. Don't let the idea of perfection distract you. Start letting your own vision be the next great masterclass on abundance. It is never too late to make that dream come true. I'm happy Brian Tracy's spark burns brightly and can still inspire so very many. All right, you guys. Well, that wraps up today's episode. I really hope you enjoyed the spotlights I put on the month's fraud, waste, and abuse cases. There were a lot of them that were really, really fantastic, really, really useful for the everyday auditing and quality auditing work that I do. Really, really helpful for the EKG strips, really, really helpful for the urological types of services, a lot of great facts for psychotherapy services, right? Our practitioners have to be in the United States for these things to be billed out under their name. So a lot of great pro tips that are definitely provided in my month-end spotlights on fraud, waste, and abuse cases. So I always get a big kick out of that. And I really love the updates that my MAC in my region is providing for the month of April. A lot of great FAQs that have been updated. A lot more questions came in the recent months. And so I'm glad they took the time to develop a lot of answers. And so for today, I really wanted to focus on documentation, which of course I talk about almost every single week, I think, for a number of years now in my Trusty tips. So I hope you guys got a lot out of that finding, because it really is important for you to analyze documentation, again, according to the payers that are in your payer matrix. And so for this particular Trusty tip today, it was all about documentation for NGS in this region and what their thoughts are on best practice recommendations. And I love that they give it to their providers in the region. So I hope you guys got a lot out of that one. So anyways, you guys, the month is over in just one day, right? And the month of May is going to start up, and we have a lot to look forward to. We have May the 4th be with you. We have Cinco de Mayo. We have Mother's Day, and we have Memorial Day. So very much to look forward to, indulge in, celebrate, and reflect upon. All right, you guys, I wish you all an amazing and very, very happy week ahead. Thank you so much for listening on today's episode. And I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.